So I have reviewed just over 1,000 papers published in the period 2018 to 2019 and picked out what I can present in 15 minutes. There is quite a lot actually out there, mainly around the refinement of CRT rather than any new indications for CRT. And I will be talking about various studies, the most prominent of which actually is a very small study, but very significant study, in which patients who were super responders to CRT, so these are patients with normalized left ventricular function following CRT, were randomized to removing CRT or remaining on CRT. And that revealed that after you stop CRT for 3 to 6 months, actually your ejection fraction deteriorates following that. That's a very simple study, but it's a very important study because some people are beginning to question whether to remove CRT in patients who have responded. So there's the answer. And it's similar to some studies that were undertaken by CMU a long time ago. So there is very good evidence for continuation of CRT even in responders, and particularly in responders. There are several studies looking into how CRT can be optimized. One of them is the study looking at the role of AV node ablation, a randomized controlled trial, confidently showing that ablating the AV node and applying CRT is much better than rate control. That's largely due to the removal of fusion and allowing the CRT to exert its maximum potential. There are various other studies looking at how to use implantable monitors. The HeartLogic is one of those algorithms used by the Boston devices. That has quite a lot of data behind it actually, and I'll be discussing that in a separate session during the Congress, but I think it's probably ready for clinical use and evaluation by clinicians, and that's certainly an advantage for patients that don't respond to CRT actually. There is a number of other studies just looking at lead positioning and how putting the lead in CRT away from scar might be useful. There is one particular study looking at cardiac MRI in relation to response, and this is a randomized trial. Again, a small study, but actually it hit the primary endpoint, showing that using cardiac MRI rather than using QLV, which some people use, is actually preferable in terms of dramatically reducing the combined endpoint of heart failure hospitalizations and mortality. And that's more or less really what I'm going to present.